Hey everyone, welcome to our first seminar series in the Medical Humanities program for the Social Equity Action Lab. My name is Om Gandhi. I'm a Rhodes Scholar, first year Rhodes Scholar at Oxford, studying a DPhil in cancer immunology. And so the Medical Humanities group, that's part of SEAL, really tries to explore how we can bridge the gap between medical advances and meaningful improvements in health across the world, drawing on history, philosophy, patient narratives, and bioethics. So we're really excited to have Dr. Arthur Caplan to be our inaugural speaker in this seminar series. It's my pleasure to welcome him, and I'll start with a brief introduction. And so Dr. Caplan is the Dr. William F. and Virginia Connolly Mitty Professor of Bioethics and founding director of the Division of Medical Ethics at New York University Grossman School of Medicine. Over a distinguished career spanning more than 4 decades, he has shaped critical health policies that affect millions of Americans, from helping establish the National Marrow Donor Program to advising on the National Organ Transplant Act of 1984 and creating the required request policy for organ donation used nationwide. He's a prolific scholar. He has authored or edited more than 35 books and published over 860 peer-reviewed papers on topics ranging from genetics and organ transplantation to pandemic response and medical research ethics. His work extends far beyond academia. He's been named one of the most influential people in American healthcare by Modern Healthcare, recognized as one of the 10 most influential people in science by Discover magazine, and honored with 8 honorary degrees. Dr. Caplan has also never shied from the public square. He secured the first apology for the Tuskegee syphilis study, advising United Nations on human cloning, and spent much of the past few years immersed in the ethical challenges of the COVID-19 pandemic, from vaccine trial design to transplant policy for the unvaccinated. He's a regular presence on CNN and writes extensively for general audiences. He believes firmly that ethics should change behavior and not just fill journals. And so please join me in welcoming Dr. Arthur Caplan. This session will be co-run by me and Tej Patel, who is a Marshall Scholar at Oxford. Um, so, just want to start pretty broad and see where the discussion takes us. My first question is, what's an ethical issue that everyone thinks is settled that you believe we've gotten fundamentally wrong?
The brain drive the heart, and you're going to basically be dead because you have no more thermostat to permit heart function. So you can be pronounced brain dead when there is total and irreversible loss of all organized brain function. Big mouthful, but that's to do that. Again, you have to be on machines. You're going to need your respiration supported. You're going to need your blood flow maintained. And you may even need things like some blood pressure meds, something to control diabetes, which sometimes accompanies death. You don't want to damage the organs, right? Everybody with me on this? So that really limits the number of people who can be organ donors. So the argument has come up, well, maybe we should start to try and figure out ways to use people who die from cardiac death but are not on life support. One way to do that is to bring them to the ICU and let them die there if you think their heart's going to fail, or if they're what's called do not resuscitate. We're not going to try to resuscitate them. So they wouldn't normally go to the ICU, but maybe you bring them there just to make organ procurement from the dead possible. Or maybe someone who suffers a cardiac stoppage could be put on a special pump outside the ICU and support their organ, if you will, blood flow and functionality. So we have techniques, you can look these up later, that are just coming in. One's called normothermic perfusion. There's another one that's kind of an artificial heart in a box that you would deploy quickly. But to get back to Am's question, what seems settled, you're dead when your heart stops. Actually, there's a lot of variability about when people pronounce that, and that can make families a little nervous. They're sort of like, did you try hard enough? Did you do everything possible? So you get some pushback because different teams will pronounce death under different circumstances, cardiac death. And then we have brain death, which makes people nervous because the body is still being maintained, even though death has come. but you're artificially maintaining the body. If a relative goes in and looks at the body, it's breathing, it looks pink. That makes people nervous. And then if you're going to try and maintain somebody just to get their organs, you take them down the ICU, the family starts to say, oh, well, then I guess they're going to live. That's why you brought them in to the ICU. And you're so like, no, we just wanted to give you an opportunity to decide if you wanted to donate organs. And that gets confusing. So that's an area that is high confusion right now, even though ordinary people probably think they know when you're dead. That's at least one thing we can all agree on. Not so much.
That makes a lot of sense. Thank you for that.
Great.
And by the
Hi, Dr.
way,
Caplan.
when if I call on you, you speak to me, just tell me who you are. You just do a little intro and keep your cameras on if you can. It's just easier for me to have a discussion if I can see you.
Sorry, yeah, I can go ahead. My name is Tej Patel. I'm co-moderating this panel with Om today. I'm one of the co-founders of the Social Equity Action Lab as well. I am a Marshall Scholar at Oxford right now doing my MSc in Global Health and Epidemiology. So I'll be spending a year here doing that. I kind of wanted to ask about sort of your thoughts on how we're moving sort of from an informed consent state to a terms of service medicine state with the introduction of AI. I think AI obviously is primed to change a lot of how we deliver services to patients and how I guess the patient is still at the center of all the healthcare services we deliver. I'm kind of curious for your perspective. Do you think that the era of meaningful consent is already dead or is being like really hard, like threatened right now?
Yeah, it's a great question. Very timely. And yes, I do. I think it's under extreme threat. There are a lot of companies online who will already, if you will, manage your care with very little attention to informed consent. I asked some of my med students here at NYU to go to RO. Do you know what that site is? RO. It's one of many that you will give you medications online. You can get pills for impotence. You can get pills for depression. They will sell you a pretty wide variety of prescription drugs. So when you go on, what we learned was they basically say a licensed doctor will review your request for whatever the drug is, and if they approve it, then you'll get it. In no case did it take longer than 30 seconds to get approval. In no case did they ever tell you who the licensed professional was. I don't even know what country they were in, much less what specialty they're in. In no case did they ever say, are you depressed because you had a family member die? Are you suicidal? Are you, you know what I mean? They didn't probe anything. They just said, well, let's, help you feel better. If you were impotent, they didn't say, do you have diabetes? Do you have cardiac issues? Are you in a bad relationship? There was nothing. It was like, take this. So that's clear evidence that there is slippage. Secondly, on the terms of agreement, as you put it, I don't even know who's liable if they prescribed wrong or somebody said, my child got a hold of this and you sent them medications and they took them and they hurt themselves. The programmer, the company, that doctor in, I don't know, Grenada, who said, okay, I'll sign off on that. It isn't clear what liability is, nor is it clear what malpractice is. More and more companies are forming basically to deliver care with no doctor sign off. There's a couple announced actually this month. I forgot the names, but they're basically saying we'll be your primary care resource. I get it because in some ways, trying to find a primary care person in the UK to get on that registry or the US, it can be very hard. Waiting times are bad. Those docs are overwhelmed. Some of them feel so overwhelmed, as you all know on this call, they're going to what's called concierge practice. You pay me additional money, I'll pay attention to you. That seems like a sad uh, necessity. I have to pay you to pay attention to me, but that's what you see. And I think, again, informed consent is non existent in these settings. Even the advice that they give or recommendations. Let's say I put something up online, say I have this growth or blemish. Is it okay? And I get an answer back. Professional societies have not vetted the responses. It's not peer reviewed. It's just sometimes what open source stuff pulls off the internet, and we all know how good that is. So it's trouble. And I think before AI gets much further into healthcare, we do need some agreements, both on what an adequate consent is, transparency of who your provider is, what the database is that's being accessed to supply you with advice. Is it certified or uh, vetted by, competent professional society somewhere in some country? Um, but it's not waiting for that. It's moving really fast. And that partly is due to this manpower shortage. It's partly due to convenience. If you ask somebody, why don't you know, go online to get an answer about your migraines? And they're going to say, because it's going to take me a month to get to the doc. I don't really have the money. I'm going to have to take a bus across town. I got to get a babysitter for my kid. I'll live with grok.
That was great. So just following up on this idea of technology and science that's moving very, very quickly. You've advised the UN on cloning, the Olympics, DARPA on synthetic biology. And I guess, all of these technologies are moving incredibly quickly. And at what point when you're advising sort of these organizations and setting um, policy based on based on your knowledge of ethics, how often is the real answer? We don't actually know what we're doing yet on the science side. And how do you create tangible policy based on science that's moving so quickly or science that we don't even fully understand yet? I guess I'm very interested on how we translate some of the theories that we read about in the textbooks to actual tangible policy for all of these different organizations that you've worked with.
Yeah, another good question. By the way, Larry Kaiser just came to me, the guy at the Motor Museum. Anyway, so this is a challenge that is appropriate to put to me or question because I've been thinking about this my whole career because I've been doing advice on cutting edge science probably as much as any other bioethics person has tried to do it. So first, I came to bioethics more from the science end. I was more on the biological sciences than I was coming out of philosophy or religion or the law. So a little background there that got me some street cred with the scientists. And I feel like I can at least get some of the cutting edge stuff translated to me. So when we broke through with gene therapy at Penn when I was there, I knew roughly what it was about and what they were trying to do. Later, CRISPR appeared, and I wouldn't say I was going to write papers on CRISPR, but I could at least track what was the theory behind trying to do gene modification outside the body, get it back into the body, and get it in the right place. So the first requirement is you need bioethicists who have some good science background. I mean, that's just important. Your science colleagues are not going to pay attention to it if they think, well, it's great that he knows the Bible, but, not sure I'm up to that, or the Quran, or whatever uh, religious expertise you might have. And I'm not knocking that expertise. It's just they're not going to credit it as something that they want to have conversations with. Second thing, you've got to be engaged right from the start. So when I've been at different universities, I've always tried to get friendly with the cutting edge science guys. At Penn, I became very close to Paul Offit, who's in the Children's Hospital of Philadelphia and a real vaccine pioneer. And he said, well, I wouldn't normally suggest this, but I know that Merck has a very good course on how to make vaccines, and you should go take it, which I did. And so at least I know how to make a vaccine using that technology. By the way, it's been what I learned has been replaced by better technology, but nonetheless, the principle is there. Try and team up early with relevant science types. You guys would be great partners down the road. You got interests in ethics and policy, and yet many of you will go into a scientific research career. Immunotherapies right now, something I'm trying to stay abreast of, see what's going on, so at least I can raise an intelligent question. The third thing to do, I think, in the sort of cutting edge space is not just be there as the policeman or somebody to say no or you can't do it. I'll give you a concrete example. This will amuse some of you. So we were trying work, as some of you know, at NYU, we have a big program on using pigs as sources of organ for transplantation. And those pigs have to be genetically engineered to tune down their immune systems, plus kill the potential for the transmission of viruses from them to humans, the humans being very immunosuppressed, so it's not a good thing if a pig virus makes a voyage. And so already we're not sure what the hell we're doing because we're not sure we can shut off all the pig viruses, and we're not sure how to balance the immunosuppression enough so that the organ isn't rejected, but the virus might still be killed by the recipient. Other issues around how to do the surgery, other issues around what's a pig that's been kept under appropriate stress-free and healthy conditions. These are not, farm animals that you might have some people eating for food. These are got to be specially raised, not just genetically engineered, but not infected, highly stress-free. I sometimes tell some of the people who worry about animal welfare using pigs that these are the happiest pigs ever on the planet. They do get killed, but they're not, this is not factory farming. So the point here being in trying to track the use of these organs in people, I was thinking, it might be possible to tie back to something I mentioned earlier, to use a newly dead person who is brain dead, but still supported by machines as your first test base. Why don't we try putting some of the organs in them? Maybe 24 hours, 48 hours, see if you got acute rejection or see whatever else, viral transmission, anything. And my science and medical colleagues said, that's crazy. You can't do that. What are you, nuts? We can't do research on dead people. And I said, yes, you can. And if you looked at in the US, the Uniform Anatomical Gift Act, it says, I want to donate my organs for transplant or, if not possible, research. It was always part of the consent process. So if we came up with, to come back to Tej's question, the right consent for the person before they died or family members if they're newly pronounced brain dead, and we were confident that they would want to do this because they had a donor card and wanted to help advance transplant. This is a way they could do it if for some reason they weren't eligible to be organ donors. They had cancer, they were too old, whatever. They couldn't be donors. And long story short, we have instituted that protocol. We are using dead bodies. Other science groups are starting to think about their use in cancer research, genetics research. So sometimes you want to be there early, but you're not just there as a person to say, oh, I'm worried about this. Or I was like, well, how can we go faster? What could the ethics guy think of being experienced around the management of dying people and organ donation that might open a door to safer research in the early stages? And that's worked. You come up with an idea like that, you get no problem in the future from your science friends. They're like, that guy brought us a real gift. And there have been a few of those in my career over the years where, you sort of come up with a workaround or an idea. You can say, well, this might be ethical to try, and maybe you could go a little faster in doing it. Why do I want to go a little faster? Because when I talk to patients, nobody ever said, oh, please go slower. Please tie me up in bureaucracy. Please make sure there's plenty of paperwork before you can try something on me. So get there early, try to study it, know what you're talking about, show up at the right seminars, even if 3/4 of it goes over your head, at least you're absorbing something about what's taking place in the space. Get involved with the research team early. Try to think about ways that maybe you could help them, not just hinder them saying, you don't know what you're doing. You got to stop doing whatever it is you're doing. Although occasionally you might want to say that. I've said that in my life, but it's not all that. So does that make sense?
That makes sense. Thank you so much. I appreciate the granularity of the example, and the roadmap to sort of taking theory and putting into practice.
Yeah. I actually wanted to go back on an earlier point you made in that answer. I think, I also graduated from Penn, so I'm pretty aware of all the cell therapies and gene therapies that are sort of going on in the labs. And I think one observation I've made is that the sticker prices for these therapies are incredibly high. And oftentimes, if you look at sort of the trial inclusion criteria for some of the seminal trials, they're not representative of patients in like low and middle income countries, for instance. So I kind of wanted to ask you like a bigger question here, like how much do you think financial incentives, especially in the US, are quietly corrupting ethical decision making? And sort of what is the step forward for all these innovative therapies that are coming out of the pipelines right now?
Well, another huge area with lots of ethics issues there. I was an advisor to a big foundation, new one in Saudi Arabia, of all places, that's trying to develop research protocols to help extend longevity through biological interventions. They're not against exercise or better diets or whatever, but their tack is fund people who can alter a telomere or fund somebody who can get rid of, free radicals floating, whatever the idea is. And I said to them as a new foundation, why don't we make this commitment that we're always going to ask people who apply for money, it's called Hevolution, evolution with an H. I didn't name it. Don't ask me. I'm not even sure what the heck that is. But anyway, they have a lot of money. And let's ask people to explain to us why they think the research will be available to all. What steps can they take? If they come up with research that extends the life of, Jeff Bezos and Mark Zuckerberg because they could afford it, well, I doubt we're going to throw it away, but it isn't really the goal of the foundation, which should be to help humanity have at least the most reasonable lifespan of healthy living, or maybe extend it and live well as well. And the foundation did it. Now, can every team answer that question? No, but at least putting the principle that equity access is important to the funder and it might help you get priority over another group if you could say something about, oh, well, the intervention's cheap, or we'll be able to do this. We could set up programs in many countries who could handle the biological modulation, which, you can't do for a lot of, I don't think we're going to see CRISPR in Mali anytime soon or, Chad. So uh, that's one way to do it is as an ethicist, get your funders to commit. They're the drivers. It's not the researchers. It's the money guys. If they care, it'll make a difference. One other quick comment on the rare diseases. I think you're stuck because almost all of them are so unaffordable that only the rich can fund them. So you're going to see some funding of rich diseases again in the Middle East. A lot of those countries have high rates of intermarriage. They've got some pretty high rates of oddball diseases, kind of like Orthodox Jews or the Amish or other groups that intermarry. Uh, we do see proposals coming in, for funding rare disease research out of the Middle East. Jim Wilson, the scientist back at Penn. What I said to him was, if we're going to do research like that on rare diseases, maybe we could get a government to help support us to at least make some of it available. And he has a program for certain types of gene therapy for rare diseases with the government of Brazil. They're not a poor country, they're sort of in the middle, but they've agreed to participate along with rich people. So that's another model. See if you could get at least one site to say, well, at least for Brazil, we're going to do our best to make sure that finances are not a burden. But honest answer, they do drive things. These are band-aids. The bulk of stuff, the rich still have huge advantages. I mean, I'm not against band-aids. They're okay. Trying. And I'll take my little victories where I can get them, but they're little victories. I wouldn't claim otherwise.
Sounds good. I think now we can open it up to the rest of the audience. So if anyone has any questions, feel free to raise your hand and
Hey,
and,
before
and
we
ask
do
away.
that, let me tell you about
Yeah.
something that I've been working on today.
Yeah, great.
So, some of you know that we have this big vaccine schedule in the US. And among the recommended vaccines is one for hepatitis B, which traditionally has been given within 24 hours after birth. Transmission is possible through fluid and blood contact. So if the mom is infected with hepatitis B, she could transmit it to the baby. You try to get a vaccine into that baby to boost the baby's immunity in case there was a viral transmission, although it's sometimes a little late. You're also watching for cuts, scratches, anything that the kid might be exposed to over the next few months. And any of you who've had kids or got siblings, they're biting and scratching and the dog scratch. I mean, they get beat up all ways to Sunday. So getting the Hep B shot early has been part of the recommendation. There are follow-up shots, but we don't have to worry about that now. Kennedy showed up at HHS and he didn't like vaccines. And one of the ones he says we don't really need is this Hep B at birth vaccine. There are at least one country, Denmark, uh, doesn't actually do that. Although if you looked at the hepatitis B incidence, they have none and we have some. So part of the reason they don't do it is they don't have what we have. In any event, he has pulled the recommendation out of our childhood vaccine schedule for at birth Hep B shot. You get it later now. You would get it at the baby at 6 months or something. I think that's a stupid maneuver. But worse, out of the blue, they have decided to fund a study to see whether Hep B vaccine at birth is safe. Now, this thing's been given in the US forever. Nobody's ever worried about its safety. They picked a country, Guinea-Bissau. I will give extra credit today to anybody who can tell me where that is. I didn't even know where it was particularly, but I know where it is now. West coast of Africa, a very poor country, about 3 million people, dirt poor. It's in the bottom 10 of economically disadvantaged countries. So they want to do a study where they do a placebo-controlled trial. Half the group of moms in the coming year would get the Hep B at birth, and half would be in a placebo group. Guinea-Bissau is desperate to give everybody the Hep B shot at birth. They just can't afford it. And they've made it clear that next year they're going to start giving Hep B vaccination at birth to everybody in the country. So this looks to me like taking advantage of a poor country, exploiting them because they want to do it. They've already made it clear they want to do it. They just can't afford it. And the grant is going, I don't even understand this, to a team of scientists in Denmark who are kind of anti-vaccine for the reason I mentioned that it's not on their schedule, but it's not relevant to a place like Guinea-Bissau, which has huge, I think 20% of the population is infected with Hep B. This just looks hugely unethical to me. It smacks of a situation where we want the vaccine, but we can't afford it. So you're going to study us, ask a question that's been asked and answered, as the lawyers say. The thing is safe. We know this already. We don't have to study it. I think NIH is fishing for some reason to justify pulling it out of our schedule. It works, very effective. It certainly worked very well in a country with a high incidence. So I've spent today writing an op-ed that'll run soon in the Atlanta Journal paper, just sort of saying, it's not much attention, but this is like a really unethical study for the government to be sponsoring. And the worst fact is, if they took the grant, which I think is $2 million, $2 million would buy all the vaccine to vaccinate everybody with Hep B in the whole stupid country for 5 years. Um, so that's an example of trying to track what are they up to, what are they doing, get out ahead of the study, raise questions about it before it happens. I will confess, I do take let's do a public engagement, not just, in-house stuff with the journals and my colleagues on issues. But this one, I will say, it really has me irritated. I rarely say this, but it gets pretty close to Tuskegee study type stuff where you withhold a cure that you know works from a population to get an answer to a question that's a stupid question. So that's if you say, "What are you doing today?" That's what I'm doing today. I'm writing that, and I'll send it to or Tej or whoever, and they
Yes,
can
please do.
distribute it to you guys.
Definitely. This is very, very interesting. And I think, I mean, I certainly didn't know about this. So, thanks for bringing it to our attention. I think it's something that we should definitely look more into and constantly think about how we should sort of look at the actions of government administrations over time when it comes to bioethics. And I guess very, very quick question before we open it up to the audience. But is this all sort of just public grant information that you're looking at on the HHS website and that you could
Yeah.
track where the money is going essentially? Okay, cool.
Yes.
Yeah,
Yes. In fact, I even think they issued a press release on it. Now, it didn't pull much attention, but it wasn't like they were sneaking around.
right. Very interesting. All right. Bob, you have a question?
Excellent. Yes. First off, thank you so much to Professor Kaplan for speaking with all of us. I'm Bob. I'm a third year medical student at Stanford, and along with they each serve as the co-founder of SEAL. It's an absolute honor to have you here. I've been very interested in this idea of health span recently, the notion that we should focus on living longer and better health rather than simply optimizing over the raw number of years. But that framing seems to assume that you already get to live a reasonably long life, whereas in many low and middle income countries, the major ethical or a large ethical problem still seems to be that we have people who are dying young from preventable causes. So, in your opinion, does the health span over lifespan movement ignore global lifespan inequities? And what would a truly global version of health span ethics look like?
Yeah, good question. By the way, have you run into David Magnus and Mildred Cho in your wanderings out there?
I have not yet. I will
Okay,
certainly
they're
look them up
medical
though.
ethics. They run medical
Okay.
ethics at Stanford along with Holly Tabor. All three of them are my students. It's funny.
Oh,
I
wow.
was always laughing, saying, "I don't know how I didn't get to Stanford in the nice, farm campus and everything. I'm stuck in, Manhattan, sucking up bus fumes. What must be making mistakes here." Anyway, um, first of all, the billionaires who are part of this longevity thing don't care at all. They're selfish, they're egotistical, and they're just looking for interventions that would help them live longer. I have Elon Musk as a prime example here. No interest whatsoever in paying for funding, worrying about what might help poor people live longer anywhere. I don't see it in any of their discussions. They're looking for people that they can hire or pay to give them some sort of breakthroughs that would let them live healthy, longer lives. Uh, Secondly, I think there is a duty, if you're going to do research in this space, to try and figure out interventions that might be accessible to poorer people. So, if you have an idea that everybody needs to have adequate whole grains or something, or low-fat diets. Well, that's fine, but in your work, you should try to identify what might be available in Botswana as well as what might be available in Palo Alto to go on the diet. So, yes, I think there is a duty to come up with recommendations that are, if you will, extendable when possible and don't ignore, you know, people who are in more worse off conditions. Thirdly, the good news is some of the things that are involved in healthy lifespan are things that could be adopted in many places. So it turns out, you can do dietary reform in India. A lot of people eating bad diet. You can help. Some are poor, some are rich, but you can intervene and make recommendations and try to advance that. Not every intervention is, I have to do, uh, like we're saying, CRISPR on some bizarre mutation to make me live well and longer. I think the other thing to keep in mind about this is it ethical. Is the bulk of your resources, I still think, should be aimed at public health improvements for large numbers of people who are, worse off. But it doesn't mean your whole budget has to go there. You're trying to do some balance. After all, if we really said if we followed the principle that said you can't do anything to advance health unless, first of all, you solve the poor health problems of the majority of the world's population, we couldn't do anything. It wouldn't be justified. We just have to, go after infectious diseases all over the place and get rid of them and try to make sure that people had maybe even remove accidents and a lot of things you could think of that would help in very poor countries. But I think you can always reserve a piece of your budget because the missing moral contenders are future generations, and they have some claim on what we're doing today. So, yes, we do want to help everybody in the here and now or who might be around in the next 10 years. But I think you can make a moral case that we also want to find things that will help our kids or their grandkids. And that may or may not redound to people who are immediately not doing so well. So I think that's you got to sort of balance 10% to the future, 90% to now. How do you want that to go? So that's how I sort of think it through.
Got it. Excellent. I really appreciate that, Professor Kaplan. I think that's a very sort of balanced framework, one that doesn't ignore the promises that a health span focused agenda offers, but also strikes to ensure that those in LMICs and those in the bottom socioeconomic strata are not left behind either. So I appreciate that.
Awesome. I
Great.
think Orvish has a question.
Thank you so much for taking the time to speak to us and answer our questions. So in 2026, one
Tell
thing
me
that
who
will be
you are.
Oh, yes. I'm Irvish. I'm a current student in public policy at Cambridge. And so 2026 is interesting because it's the first time that a group is holding what's called the Enhanced Olympics. So it's the Olympics, but
Oh yeah,
people are
yeah,
allowed to use as many performance enhancing drugs as possible. And
yeah.
many
I
ethicists,
thought that was the current Olympics, but go ahead. Yeah.
yeah, I'm not like super familiar with the details, but
No, I'm
um,
making a joke. I think there's a lot of doping in the current Olympics, but yeah, I
oh.
think you say it.
That's funny. But the point is athletes can use as many performance enhancing drugs as they want, and if they break world records, they'll get rewards, and they will be closely monitored by medical staff. But it seems to have kind of risen an ethical debate. And so I was wondering what your take on an event like this is. Is it ethical to allow and see what the current state of our technology can allow us to do, or is it not?
So I think, I even have trouble with UFC. It seems to me a lot of the fighting that goes on there, and it's very popular and growing, still is kind of hyper dangerous to the fighters. When somebody falls down, you can keep beating them in their head. It's not exactly, this looks too dangerous to me. We had restrictions on boxing, old style boxing for this reason, and all of a sudden UFC pops up and people are pounding and kicking the crap out of each other, and I'm sure causing concussions and having bad injuries. I think that opened the doors, the reason I mentioned it, to more of the enhanced Olympics idea. I know it was around, people have always sort of said, one argument, well, so I'll give you the arguments for it. One argument is you make the choice, it's up to you. You don't want to do it, don't do it. Personal autonomy, you can do whatever you want. It's nobody's business if you drink testosterone all day and, do other, have implants put into your legs so that you can run on artificial limbs or springy things or whatever. I don't think that's actually true. I don't think you're free to do anything you want, partly because you shouldn't have the cooperation of doctors to do risky and harmful things. So maybe you want to do it. I might say, I want to produce a child who's extremely weird looking and I want to bring them to exhibits and show off their weirdness. I don't think any doctor should go along with that, even if you could do it. I don't think any doctor should be prescribing life shortening drugs or whatever. So the boundary for a person's autonomy to me is the professional's commitment not to cause harm or to do harm. Secondly, the people say with the Super Olympics or the Enhanced Olympics, well, it's unenforceable as we have now. That's why I made that joke about doping in the current Olympics. There are already people cheating, and we don't find them till later, and then we have to take their medals away, but nobody cares because they got all the glory beforehand. I don't know. That seems to me an argument. It's like we're not going to have any speeding laws because people beat them a lot. I still don't think that's a sound argument not to try to police to make competition fair, which leads me to the real problem I have with these Olympics. They're not competitions unless you think they're competitions among pharmacists. What they are is exhibitions. So, how high could a person jump fully drugged with artificial limbs? I don't consider that sports. I consider that it's like, sorry, the World Wrestling Federation or World Wrestling Entertainment. These are scripted exhibitions. They're like bodybuilding where they already have some unlimited competitions and people look crazy. But I'm not interested in that as sport. I mean, you can call it that, but it isn't. It's basically sort of a test or an exhibition thing. It's like who can grow the biggest pumpkin. It's kind of interesting, but I wouldn't call it an athletic competition. It's just like to use all the, fertilizer you want and do any crazy thing in genetically engineered seeds. Well, how big could a pumpkin be? So I don't think doctors should be doing it. Trainers shouldn't be doing it. The health side shouldn't be doing it. And then, although I'm sure there are people willing to do it, choose it. And then, to me, it's not sports.
Thank you so much. Yeah, I never thought about it from the perspective of like the doctor actually is part of like a huge part of the ethical issue there. So that was very
But just a
insightful.
little comment for those of you in medicine and around medicine. Bioethics likes to talk and is very proud of the fact that it promotes and has promoted over the years autonomy. Let the patient have more voice, let the patient have more choice. And I'm all for that. However, choice demands adequate information, no coercion, and doctors can recommend against what the person wants to do. There's nothing wrong with saying, you want to have plastic surgery for the 28th time. You're still not happy with the way you look. I would not advise that. I know you want it and I know you could pay for it, But my professional opinion is I don't think you should do that. Moreover, I'm not doing it. Nobody said in the world of autonomy you couldn't challenge somebody's choice. In fact, that is part of informed consent is to have a preference and then hold it up to criticism. So medicine isn't a restaurant. You don't go in and say, "Oh, here's the menu. I'll have chicken soup today. That'll be great." You should like ask the waiter, "Is it any good? Do I want to order this? Is that, has it been coming out okay?" I am not I am not at all persuaded when somebody says, "Well, I want to, take massive amounts of drugs," and this doctor says, "Well, if that's what you want to do, then what choice do I have?" I don't buy that. It's almost as if I said, in a class, "I want you to write a 20-page essay," and you said, "Well, I prefer 10." And I said, "Well, okay, that's your choice. Do that."
Great. I think we have time for two more questions. So, Gitika, if you want to go next.
Yeah. Hi, Dr. Kaplan. Thank you so much for the talk. My name is Gitika, and I'm currently a senior at Columbia University, and I'm studying biomedical engineering, and I'm very interested in like the area of artificial organs. So this was a very interesting talk for me, and I was really curious about more of like the legislation side of things while we're waiting for the scientific advancements to continue increasing organ transplants. I think there's a lot we could do, like through legislation. And I know you helped advise the National Organ Transplant Act to help kind of prevent coercion and commodification in organ donation. And interested in like the kidney transplant space. It's a very, painfully long transplant waiting list. 5 to 7 years, 34 people die on the transplant waiting list every single day in the US alone. And recently, like about a year ago, I came across a group that's trying to pass a legislation called the End Kidney Deaths Act. And they're trying to create like a 5-year pilot program with a $10,000 tax credit for like non-living donors who are like donating their kidneys to strangers, so non-directed donors to hopefully spark transplant chains. And at first, I was a little bit hesitant, because of the money aspect. But after listening to their arguments, I was kind of convinced with what they were trying to do and like, and I'm happy to explain what their argument was. But I'm curious from your perspective, what do you see as like an ethically acceptable evolution of the current NOTA? And how do you see us possibly trying to increase the number of living organ donors?
Well, first I have to tell you, I got my PhD at Columbia in philosophy of science, and I also spent 2.5 years at the med school there before I decided I think I'm going to do this ethics stuff, much to my mother's eternal dismay. I'm going to be a doctor. What? What? Can't have that. Or an MD one. And then I taught there for many years. So I'm often on campus. So keep your eyes open. They drag me back down there for talks. Fighting the organ donor shortage, cadaver and living, is a huge problem. The ultimate solution to this, which you have to come up with, is to be able to, one, freeze organs so that we're not always in this situation of, somebody's got to die and I got to rush Art to the hospital so he can get his kidney and it's an emergency operation. I can't tell you how nuts that is. It's nuts. And if we could come up with ways to freeze organs, which many teams are currently working on, you'd have an organ bank and you just pull it out and you could build up a reserve and all that. So part of the shortage is just due to the fact that, as I said before, there are relatively few people who die on life support who can be cadaver organ donors. And living donors is really confined to kidneys. And they've either got to do it because they want to help a loved one or a friend, or as you said, a stranger. Number of people who are actually going to come forward for 10 grand and give up a kidney in a major operation, I'm going to tell you, is very small. It's just not going to draw enough. I'm not saying nobody's life would be saved, and I'm not saying no one would do it, but that group you're talking about has this fantasy that, 10 grand tax break is going to bring hordes of people forward to have a kidney sought out of them, and I don't believe that. Now we can do surveys and studies and see what they say. I'm okay with that. Secondly, part of the reason I have trouble with that particular solution is people tend to lie about their health when they're going to sell you an organ because they already did it in the blood world. So if you had Hep B or you had HIV, you don't admit to it. You just sell your crummy kidney or your blood. And that's why we did away with paying for blood in the US many years ago because it was getting dangerous. The financial incentive was just driving the quality of the organs down. The other problem is, even though people say you can give up a kidney, no big deal, it's not true. If you look at people over time on one kidney, kidney function begins to decline. I'll put it this way, it's not the way to healthy, long living. If you got one kidney that's wearing out, you're not going to live as long. And the people who are promoting living donation just don't fess up to the fact that, or if you get diabetes or get an injury, it's aside from being a serious operation, it's not, I think, the future. So that's why we're interested in pigs. We're trying that route. I think the other solution is come up with stem cells. You know, don't report, I said this back to my transplant friends, but what we're doing now, taking organs out of dead bodies, pouring a lot of immunosuppression into the recipient and hoping we don't kill them with those drugs or that they don't get infections because they have no immune system is not elegant. Elegant is you grow and repair the cells that are damaged in your kidney or your heart or your lungs. For diabetics, transplanting a pancreas, I think 80% of it is exocrine. You don't even need it, but we just don't know how to transplant the islet cells without lugging along the rest of it. So it's growing and regenerating I don't even think the pig approach is the long-term answer. It's interim okay, but the long-term answer is for you all to come up with regenerative medicine, or as I said, freezing technologies, or both. I think that's the solution.
Yeah, that's very interesting to hear. Yeah, I'm very interested in like the
Or
organoid.
mechanical, sorry. I didn't mention 3D printed. They're fine too.
Yeah,
That's-
3D
yeah.
printing as well. Yeah, and yeah, I'm very interested in like the organoid work technology as well and
Yeah.
what they're using with regenerative medicine there. But also there's a company called 34 Lives that actually works with NYU. I don't know if you're familiar with them, but they're rescuing kidneys that would have been discarded through like
Yes.
novel perfusion
Yeah.
technology. And I worked with them this past summer and they're doing incredible work. So yeah, definitely more work like that.
I mean, and there are other, you can use older donors and older recipients. They don't need the same warranty, so to speak. You take an 80-year-old kidney and give it to an 85-year-old. Okay. That's so I think you can get clever about that. But the longer term answers, it's like, oh, and I didn't mention this too. It would be good if you could prevent some of the causes of organ failure. That's always a
Yeah,
good strategy too. Less diabetes, less alcoholism, less cardiac disease. These are good.
thank you.
Great, thank you so much. So we are at time, but Dr. Kaplan, if you have time for one more question.
Okay, sure.
Mateen, I think, has a question.
Hugely appreciated. Thank you so much for the talk, Dr. Kaplan. So just to quickly introduce myself, I'm currently an honors pharmacy student here at the Rutgers Ernest Mars School of Pharmacy. So I'm also in the tri-state. I just finished up my internship at Merck. I'm going back to Merck this upcoming summer, working on Keytruda. And I had a question. So I saw that in 2015, you collaborated with Johnson and Johnson on creating the Compassionate Use Advisory Committee. And I was really curious, just having had experience in the pharmaceutical industry, like especially with like pharmaceutical companies differing widely in size and the pipeline maturity and also the resources. How adaptable is the Compassionate Use Advisory Committee framework to companies without already the large internal ethics or legal infrastructures?
Yeah, so the idea very simply is when somebody wants a drug or a device, could be, that isn't yet approved by the FDA, still in clinical trials, is there a system that could be set up to give them access? A lot of companies, big and small, were just saying no because they didn't want to get into a situation where they're saying yes to Mateen, but no to Art. They didn't want to ration. So I said, to the companies, this is an example, by the way, of trying to be creative and move something along. I said, that's stupid. You're not going to give it to anybody because you don't want to be stuck deciding between competitive requests, so nobody gets it. That's ridiculous. That's the worst outcome. You at least ought to be giving out some, and then some people won't get it, but better some than none. So that's where the general ethical idea came from. And I set up a committee for Janssen for a drug that was what's called phase 3 in human trials, but early, but it was looking good for multiple myeloma. And in fact, Mateen, if you look it up, it's called daratumumab, and it wound up being, it's now the standard of care. It really worked, which often doesn't happen. So a lot of these things don't work out, but that one did. And the committee was international, and it had doctors and ethicists and patient advocates on it. No patient from the disease group that you're trying to distribute the drug. And we tried to build criteria. How old are you? Are you almost dead? Do you have enough time pharmacokinetically to get the drug into your body before you would die? Do you have kids? A whole list of things. And the committee took over rationing, and we basically anonymized requests. We didn't know who they were from. So rich and poor didn't differentiate. We even had people come from Johnson & Johnson, employees, and they had to go through the process. No privilege, just because they were working on that drug. It worked, and it's been emulated by big and little companies. So it can work for little guys. It works for big guys. Glaxo does it now. I think Merck does it internally now. They don't have an outside committee, but they have an internal committee that they use for compassionate use. Novartis picked it up in Switzerland. I would probably say 10 to 12 companies, Sumitomo in Japan, a bunch of them. They each style them a little differently. Some have international committees, some have local committees, some are in-house without outside people, some have outside people only. That's Johnson & Johnson, Janssen. We expanded our committee. We do almost every new drug now that comes up the pipeline through Johnson & Johnson, and some devices. So I'd say, yeah, it can work. It's worked out pretty well. The patient groups don't complain. They understand that not everybody can get whatever it is they hope for, and many have children, and many are desperate. But they believe if the committee's fair, blinded, anonymous, you can't twist our arms, and we try to do it on some criteria that they all see, they'd rather that than nothing.
Huge appreciate the answer. Thank you.
That, by the way, is an example of, I'm going to say, bioethics really getting on the side of patients, because they're very appreciative, as much as people get told no, and they do, and some, don't like it, and I get it. It got tens of thousands of people got access so far through that committee to different drugs that wouldn't have.
I was reading up an article about that. No, I know the impact is just huge. It's honestly, it's so insane to even think about it. But yeah, do appreciate your answers though. Thank you.
All right, well, I'll let you guys run off. Thanks for having me come. It was a pleasure. Great questions, by the way. Very, very good.
On behalf of SEAL, thank you so much for joining us, Dr. Caplan. It was a real treat to hear you speak.
Yep, I'm glad you got the group going. So, and I'll send you that thing on Guinea-Bissau. I got to finish it, but I'll get it to you.
Yes, please do. Thank you so much for your time and for sharing your insights.
See you now.
Great. Thanks again, Dr. Caplan. Bye.